Our speaker this morning is Dr. Valerie Earnshaw. Dr. Earnshaw earned her PhD in social psychology from the University of Connecticut with support from an NIMH Social Processes of HIV/AIDS training program. She then pursued postdoctoral training via an NIMH interdisciplinary HIV prevention training program at Yale at their Center for Interdisciplinary Research on AIDS. She spent 2 years as an instructor at Harvard Medical School and associate scientific researcher at Boston Children's Hospital, where she received early career training in child and family-centered outcomes research. Dr. Earnshaw is now an assistant professor and faculty scholar in the Department of Human Development and Family Sciences at the University of Delaware, about 2 hours north of us. She is trained in social psychology, quantitative methods, and patient-centered care, with an interest in how stigma acts as a fundamental cause of a wide range of health conditions using rigorous methodologies and advanced data analytic techniques. Her research focuses on understanding and addressing stigma to prevent common risk factors and causes of death and disability, including infectious disease, risky sexual behavior, alcohol misuse, and drug abuse. Dr. Earnshaw introduced the HIV stigma framework in a paper published in 2009, a paper that's been widely read and very influential. It describes how HIV stigma is experienced by individuals as a series of stigma mechanisms that impact HIV-related outcomes. This framework has informed research as well as primary and secondary HIV prevention interventions around the world. She will speak to us today on understanding and addressing stigma to prevent HIV/AIDS and substance use disorders. Please join me in welcoming Dr. Valerie Earnshaw, winner of the 2019 ODP Early-Stage Investigator Award.
So thank you, Dr. Murray, for that kind introduction, and a warm thank you to the Office of Disease Prevention for this terrific opportunity to share this lecture with you today. I'd also like to thank Ingrid Katz for nominating me for this award. Ingrid recently won an Excellence in Mentoring Award from Harvard Medical School, and she couldn't be more deserving of that award. So since I'm here and I'm not really sure when else I'd get the opportunity to do this, I'd like to take a moment to acknowledge that I wouldn't be the scientist who I am today without the support of training award programs from the NIH. I have been very lucky to have training support at every stage of my career, as Dr. Murray pointed out, from pre-doc to post-doc to early career, and from several branches of the NIH. So even though stigma research is a real bummer some days, I truly love my job, I love doing this research, and I'm very grateful to have had these opportunities. I've also been very lucky to have had excellent mentorship within these programs, including from Seth Kalichman, who introduced me to HIV research, from Jeanette Ikovics, Trace Kershaw, and Laura Bogart, and now from John Kelly, who is helping me to apply my program of research in stigma to the context of substance use disorders and recovery. I'd also like to acknowledge that I'm currently working as a co-investigator on several research awards related to stigma, disclosure, and resilience, which will relate to what I'll present today. And although I am full of acknowledgments this morning, I have no conflicts of interest to disclose. Today's talk centers on understanding and addressing stigma to prevent HIV/AIDS and substance use disorders. I'm going to walk us through 3 big picture questions this morning. First, what is stigma? Stigma is a term that is used in a colloquial or an everyday way. We often hear, or we don't often, but I've heard people talk about stigma associated with pimples, for example. But stigma has a precise scientific definition that's important to bear in mind when talking about stigma research. We're going to unpack this scientific definition and talk through some related key concepts. Second, how does stigma impact our efforts to prevent disease? We'll talk about this in the context of substance use disorders and HIV. Third, what can we do to prevent stigma or to remove this barrier that we have to our prevention efforts? I'm going to talk about some work that I'm currently doing with colleagues and then talk about the big picture stigma intervention toolkit. And I will use this bar at the top of the slides to keep track of where we are within our presentation. Now, what is the scientific definition of stigma, the definition that may preclude the existence of pimple stigma? Goffman, who was a sociologist by training, provided us with an early definition of stigma, which is that stigma is social devaluation and discrediting associated with a mark or characteristic. Because he used this mark or characteristic terminology, we often hear people refer to stigmas, by which they mean these devalued characteristics. Unfortunately, we have many examples of marks and characteristics that are socially devalued and discredited. They include physical illnesses like HIV, mental illnesses like bipolar disorder, what social psychologists such as myself sometimes refer to as social norm violations such as substance use, and certain sociodemographic characteristics like some racial and ethnic backgrounds. But when we hear people use the term stigma, they're not always referring to a specific devalued group. Sometimes they're referring to a broader social phenomenon. And that's because theorists since Goffman have really honed in on this social aspect of stigma. Theorists have highlighted that stigma results from a social process in which certain marks are constructed as indicators of tarnished character. And in turn, these marks are used to justify discrimination toward and power loss of people with those marks. This means that when we talk about stigma, we're often talking less about individual marks and characteristics and more about a broader or larger phenomenon that results from this social process. People have theorized about why stigma exists, and they've proposed that there are three primary functions of stigma. These include to keep people down, away, and in. Keeping people down refers to exploitation and domination. So some groups in society have less power and resources than other groups, and stigma helps to perpetuate these power and resource differences. Racism and sexism are examples of this type of stigma. Keeping people away refers to avoidance of disease. Theorists have argued that we've evolved processes to avoid people who may be infectious, who may harm our own health, and HIV stigma is an example of this type of stigma. Keeping people in refers to the enforcement of social norms. People who deviate from social norms are sometimes characterized as immoral. Substance use stigma is an example of keeping people in, a societal attempt to stop people from using or misusing substances. Much of our research on stigma, especially health-related stigma, or stigma associated with physical and mental disease, has occurred in a siloed way. We have had researchers studying stigma within different disease contexts without a lot of sharing between those silos or contexts. There has recently been a push to adopt more cross-cutting approaches to health-related stigma research. As an example, in 2017, Fogarty and the NIH sponsored a workshop on the science of stigma reduction, wherein we brainstormed about developing and using cross-cutting stigma theory, measures and research approaches, as well as intervention strategies to make faster progress addressing stigma across these different silos. This meeting led to a collection on stigma research and global health that was published last month in BMC Medicine. This collection further articulates the importance of developing cross-cutting approaches to health-related stigma research and evaluation. As a guest editor of the collection, I'm very proud of it, and I hope that you'll all go read it. Not right now, maybe after the talk over lunch. One of the things that a cross-cutting approach to stigma research allows us to do is to think about the processes linking stigma with health outcomes across a wide range of disease contexts. This is a pared down or simplified version of a framework to understand this process. It starts with the social process of stigma that we've been talking about so far, and then it defines ways that individuals living with stigmatized characteristics experience this stigma as a series of stigma manifestations. I'm going to take just a moment to define these because they'll continue to come up throughout today's talk. Internalized stigma is sometimes referred to as self-stigma and refers to the endorsement of negative beliefs and feelings associated with the stigma and applying them to the self. So this could include feeling like one is a bad person. Enacted stigma is sometimes referred to as experienced stigma or perceived stigma and includes experiences of discrimination from others in the past or present. This can include social rejection from friends and family. Anticipated stigma refers to expectations of discrimination in the future. This could be, for example, expecting that friends or family will reject one. Now, to further drive home this point about cross-cutting approaches, people with any stigmatized characteristic may experience these 3 stigma manifestations. For example, a woman could experience these because of her HIV, or a man could experience these because of his substance use disorder. But the way that they experience these may differ a little bit. For the woman living with HIV, she may worry that people aren't going to want to physically touch her, maybe to shake her hand or give her a hug. For the man living with a substance use disorder, he may worry that people aren't going to trust him, that doctors may not take his complaints of pain seriously because they think that he's pill shopping or trying to get pain medication that isn't medically necessary. Returning to our figure, these experiences of stigma, in turn, are related to a suite of biopsychosocial mechanisms. Experiences of stigma affect people's health behaviors and are associated with increased stress and biological changes. These biopsychosocial experiences lastly lead to worse mental and physical health. We're going to apply this broad understanding of stigma and how it works to the context of substance use disorders and HIV today, but we could also apply it to other disease contexts. We could be talking about epilepsy, tuberculosis, obesity today. In addition to cross-cutting approaches, stigma researchers are increasingly adopting an intersectional lens within our work. Intersectionality theory highlights that people live with a range of intersecting characteristics or identities. These represent both dimensions of privilege or power as well as vulnerability. The theory holds that these characteristics lead to unique experiences for individuals, including experiences related to stigma. If we were to apply this lens to HIV, we might think about people's experiences in relation to their HIV, but also their race, gender, class, substance use, and sexuality. We might even think about it in relation to other characteristics that we can't fit on the slide. Stigma intersectionality theory tells us that to really understand how stigma is experienced by individuals and how it affects their outcomes, we need to study these different dimensions simultaneously and in an interactive way. I think this quote really nicely illustrates intersectionality, and it comes from a qualitative paper by Dr. Lisa Boleg. The participant in this study, who was a Black gay man, said, "Well, it's hard for me to separate my identities." And in the context of this study, he's referring to his race, gender, and sexual identity. "When I'm thinking of me, I'm thinking of all of them as me. Like once you've blended the cake, you can't take the parts back to the main ingredients." To me, this suggests that all of these characteristics, his race, his gender, and sexual orientation, shape his life, including his experiences of stigma. So we'll come back to this concept of intersectionality toward the end of the talk. How does stigma impact or get in the way of our prevention in the context of substance use disorders and HIV? We'll start with stigma and substance use disorders. And I'll begin by reviewing evidence linking stigma to substance use, the initiation of use, and the frequency or amount of use. There is a good amount of literature out there suggesting that adults who experience more stigma associated with a wide range of characteristics engage in more substance use. Echoing back to our cross-cutting theme, we see this pattern of findings in different research silos. Here are just a few examples of studies from the LGBTQ and race stigma literatures. This research suggests that people who experience enacted stigma, those experiences of poor treatment from others based on their sexual orientation, their gender identity, maybe their race or ethnicity, cope with these experiences via substance use, including alcohol, tobacco, marijuana, and other illicit substances. Stigma is related to both likelihood of use and more frequent or disordered use of substances. Lately, I've become more interested in examining these processes among youth for 2 reasons. First, there's some research and theory to suggest that individuals may be more vulnerable to stigma and other forms of mistreatment when they're young. Second, substance use is often initiated during adolescence and early adulthood, and youth can be at increased risk of developing substance use disorders during this time period. Which means that we have this alarming confluence of a developmental period when young people are more sensitive to mistreatment, paired with this period when they're initiating and experimenting with substance use. My colleagues and I wanted to know the extent to which early experiences of peer victimization in 5th grade predict substance use in later years, in 10th grade. We also wanted to know whether depressive symptoms mediate this association. That is, whether peer victimization is associated with depressive symptoms, which in turn would be associated with substance use in later years. We used data from the Healthy Passages dataset, which is a 3-wave longitudinal dataset including over 4,000 youth from public schools in Alabama, Texas, and California. Data came from self-report surveys, and we used structural equation modeling to analyze the data. I apologize that the table came out a little bit small here. But the important thing to look at is that by 10th grade, 24% of the youth reported alcohol use, 15% reported marijuana use, and 12% reported tobacco use within the past 30 days. Turning to our results, what we can see here is that experiences of peer victimization in the 5th grade were associated with greater depressive symptoms in the 7th grade. And in turn, greater depressive symptoms in the 7th grade were associated with the use of alcohol, marijuana, and tobacco within the past 30 days in 10th grade. Importantly, our measure of peer victimization was broad. It included youth who were experiencing mistreatment from other youth based on a stigmatized characteristic, which I would argue is a form of enacted stigma, in addition to youth experiencing victimization to another reason. I would hypothesize that these associations that we observed would be even worse if we just narrowed in on those youth who are experiencing peer victimization due to a stigmatized identity or characteristic in 5th grade. Let me show you why. Russell and colleagues have looked at associations between general experiences of peer victimization with substance use, as well as associations between peer victimization due to a stigmatized identity or characteristic with substance use. These are cross-sectional data from the California Healthy Kids Survey, which included over 600,000 youth in grades 6 through 12. Russell and colleagues also show that peer victimization is associated with greater likelihood of past month and lifetime substance use. And this spans smoking, alcohol, binge drinking, marijuana inhalant, and methamphetamine use. But then Russell and colleagues also show that peer victimization due to a stigmatized identity or characteristic, which I would categorize as enacted stigma, is associated with an even higher likelihood of substance use across the board. So just as an example, the size of the odds ratio representing the association between non-bias-based or non-stigma-based peer victimization and methamphetamine use in the sample was 1.41. But then it jumps to 5.27 for peer victimization based on sexual orientation, and all the way up to 7.57 for peer victimization based on disability. This suggests that mistreatment during these early years is associated with substance use, but if the mistreatment is due to a stigmatized identity or characteristic, if it's a form of enacted stigma, then it may play an even stronger role or be a stronger predictor of substance use. Some of these youth will develop a substance use disorder. They will engage in the recurrent use of substances, leading to some sort of clinically or functionally significant impairment. And some of these youth who develop a substance use disorder will initiate treatment. If we can get these youth to initiate treatment early, we can prevent the development of more severe substance use disorders. And if we can get these youth into sustained recovery, we can prevent the development of a range of health consequences of substance use disorders, such as heart and lung disease, cancer, mental illness, hepatitis, and HIV. But it's possible that stigma associated with substance use disorders undermines treatment initiation and recovery. To explore this, my colleagues and I conducted qualitative interviews with 19 young people receiving substance use disorder treatment at an adolescent clinic. They ranged in age from 13 to 25, so this was a wide developmental span, but it tracked on to our clinic population. First, I'll highlight that these participants told us about significant experiences of stigma from others. They talked about losing friends, family members treating them differently, and worrying that others would think that they couldn't be trusted. We also found evidence that this stigma undermined initiation of treatment and recovery. You talked about how they didn't want to get help because they anticipated stigma. They thought that other people at their high school would talk about them. They also talked about how they coped with ongoing stigma associated with their substance use disorder in the same way that people cope with enacted stigma associated with their sexual orientation or their race, by continuing to engage in substance use. I'm working with Jennifer Carano at the University of Delaware now to look at some of these processes over time using quantitative methods. We're following adults in sober living homes over 10 months and seeing if changes in stigma are associated with recovery-related outcomes, including continued substance use. I'm now going to shift gears and focus on the role of stigma in HIV prevention. In the context of HIV prevention, we can first think about the role of stigma in primary prevention, preventing people from becoming infected with HIV in the first place. Substance use and sexual risk behaviors are often what place people at risk of HIV. We just talked about stigma and substance use, so we're going to focus here on stigma and sexual risk behaviors. In this study, my colleagues and I were interested in exploring whether enacted stigma is associated with HIV sexual risk behaviors, including having sex without a condom, having had sex with a risky partner, as we coded it, which was defined here as someone who has HIV or someone who might be at a higher risk of HIV, for example, someone who has injected drugs. We also looked at whether enacted stigma is associated with a new sexually transmitted infection diagnosis, because STIs represent a risk factor for HIV. We focused on pregnant women who were quite young, aged 14 to 21, all of whom identified as Latina or Black or African American. This population is at increased risk of HIV. For this analysis, we looked at the subset of women in our sample who reported having sex in their second and third trimesters of pregnancy. Participants completed self-report surveys during these two trimesters. What you can see here is that in the third trimester, about 70% of women were having sex without condoms, 26% reported sex with what we coded as a risky sexual partner, and 16% reported a new sexually transmitted infection since their second trimester. Our analyses suggested that experiences of enacted stigma, which were measured as everyday discrimination, were associated with greater likelihood of having had sex without a condom, having had sex with a risky partner, and having a new STI diagnosis in that third trimester of pregnancy. Interestingly, enacted stigma was associated with these outcomes even after controlling for sociodemographic characteristics and other things that we might think play an important role in these outcomes, including sexual risk knowledge and condom use, norms, attitudes, and self-efficacy. In this study, enacted stigma was measured with the Everyday Discrimination Scale, which measures general experiences of enacted stigma. These women reported experiencing stigma associated with their race, their age, which might be some sort of proxy for being young and pregnant, gender, language, as well as other characteristics. Okay, we have evidence that stigma leads to behaviors that put people at risk of HIV, both substance use behaviors as well as sexual risk behaviors. We can also think about the role of stigma in secondary prevention, preventing people from transmitting HIV onwards to others. To do this, we may want to focus on getting people to begin medication, antiretroviral therapy, because data suggests that HIV is not transmitted when viral load is suppressed. We may also want to focus on disclosure, because if people living with HIV have conversations with their sex or their needle-sharing partners about their HIV, then they have an opportunity to discuss prevention strategies together. This could include condom use, pre-exposure prophylaxis, which prevents HIV, or other strategies. I've done some work on ART initiation among or with people living with HIV in South Africa, along with Ingrid Katz and others. In this study, we focused on people who had tested positive for HIV, knew that they were eligible for ART, but didn't initiate ART. We explored the reasons why they didn't initiate ART within qualitative, semi-structured interviews. We spoke with 20 people living with HIV here and 10 healthcare providers. In these interviews, both people living with HIV and healthcare providers talked about anticipated stigma as a barrier to ART initiation. Participants who hadn't yet disclosed at home were worried that others would see them at the clinic and gossip about them. Providers talked about how this gossip placed people, but especially women, at risk of violence from their partners. In this study, these expectations of being treated poorly by others in the future seem to be a barrier to ART initiation. Now, some of our other work has suggested that internalized stigma, feeling like I'm a bad person due to my HIV, is an additional barrier to ART initiation. We examined this within an additional study. We used longitudinal quantitative data to examine whether internalized stigma was associated with lower likelihood of ART initiation and viral load suppression among almost 400 people living with HIV in South Africa. People living with HIV in this study responded to surveys 1 week and then 3 months after their HIV diagnosis. They reported on their internalized HIV stigma, as well as the extent to which they were engaging in avoidant coping. For example, avoiding thinking about their problems. We abstracted information about ART initiation and HIV-1 RNA suppression from their medical records at 6 and 9 months after diagnosis. And I'll just highlight here that at 6 months, only 57% of participants had initiated ART, and at 9 months, only 28% of them were virally suppressed. We analyzed these data using path analysis, and this allowed us to test whether internalized stigma was associated with either of these outcomes via avoidant coping. We found that internalized stigma 1 week after HIV diagnosis was associated with greater avoidant coping 3 months after diagnosis. And this avoidant coping, in turn, was associated with a lower likelihood of ART initiation at 6 months. This model represented a good fit for the data, and there was a significant indirect effect from internalized stigma at 1 week all the way out to ART initiation at 6 months. We tested the same model, but with viral load suppression as the outcome, and we again found this association between internalized stigma and avoidant coping. And we also found that avoidant coping at 3 months was associated with lower likelihood of viral load suppression at 9 months. The model again fit the data well, and there was a significant indirect effect between our measure of internalized stigma at 1 week all the way out to viral load suppression at 9 months. I find these results to be concerning in light of emerging findings from this data set as well as others, suggesting that internalized stigma may be highest on average immediately after HIV diagnosis and then appears to decrease some. Therefore, this time period right after diagnosis may be a vulnerable one, wherein people are experiencing heightened HIV stigma, and this stigma has an important downstream effect on behaviors and health outcomes. Turning to disclosure. Recall that we mentioned that disclosure can be important for secondary prevention efforts because it can lead to conversations about condom use, PrEP, or other prevention technologies and opportunities. In this study, we explored whether internalized stigma was also associated with disclosure to sex partners. This study included 156 Black men living with HIV who have sex with men in Atlanta, Georgia. I'll highlight here that 28% of men in this sample said that their last sexual partner did not know about their HIV status. We found here that internalized stigma was associated with lower likelihood of disclosure to these sex partners, controlling for depressive symptoms and socio-demographic characteristics. A key caveat for this finding is that we were really focused in on disclosure in this study. To get a more complete picture of risk, we'd really want to know more about the participants' viral load and whether they were using condoms. And if we were to do the study today, we'd also want to know if their partners were on PrEP. Nonetheless, the study and many others suggest that stigma is a barrier to talking about one's HIV status with others, including sexual partners. Now, as promised, a quick glimpse into intersectionality. Thus far, we've been talking about stigma associated with substance use disorders and HIV separately. But given that substance use disorders are a risk factor for HIV, we know that many people living with HIV have a history of substance use or a substance use disorder. My colleague, Laramie Smith, and I were interested to know how internalized stigma associated with both HIV and substance use disorders relate to depressive symptoms. In the context of prevention, depression is important to consider because it undermines people's ability to be adherent to ART and to achieve and maintain viral load suppression. Our data came from a small sample of people living with HIV with histories of substance use recruited from the Bronx. It was a cross-sectional survey, and we analyzed the data using linear regression. We found a statistically significant interaction between internalized HIV stigma and internalized substance use stigma. And then we graphed it. And this graph shows the relationship between internalized HIV stigma and depressive symptoms. And here we're treating substance use stigma as our moderator. It suggests that participants who internalized HIV stigma to a strong degree experience depressive symptoms if they also internalize substance use stigma to a strong degree. This study suggests that the combination of internalizing stigma associated with both HIV and substance use may be associated with greater depressive symptoms. A talk about stigma never feels complete or satisfying until we brainstorm about how to fix it, which lands us at what can we do about stigma? Most of my work has focused on understanding the role of stigma in health outcomes, which is what we've been reviewing. With support from my K01, I'm starting to transition, and I'm currently gaining training in intervention science to try to do something about it. The long-term goal of any optimistic stigma scientist is to eliminate stigma. But any realist stigma scientist realizes that this will take some time. And while we try to eliminate stigma, people will continue to be harmed by it. Thus, some of my work has focused on helping people to be more resilient to stigma or to navigate stigma within their lives so that even if they do experience it, it won't be harmful or it won't be as harmful as it might otherwise be. So examples of this work include supporting disclosure decisions among people in recovery from substance use disorders, which is the focus of my K01 project. I think of disclosure as a doorway. When people walk through that door, they may encounter stigma, which evidence suggests undermines or harms recovery, or they may encounter social support, which evidence suggests facilitates or helps recovery. Some research suggests that actually the way in which we walk through that door, how we disclose to others, relates to whether people encounter stigma or social support on the other side. But our research is showing that people have a really hard time making these disclosure decisions, figuring out how to walk through that door. They may struggle with whether, to whom, when, what, and how to disclose. Some people are very guarded, telling very few people that they're in recovery, whereas others are very open, telling many people about their recovery. We recently took a closer look at comfort with disclosure within a cross-sectional, nationally representative sample of about 2,000 people who have resolved an alcohol or other drug use problem. These scatter plots show the association between years since problem resolution and comfort with disclosure, with locally weighted smoothing lines going across. This graph on the, This graph on the left spans the first 5 years after problem resolution. It suggests that disclosure comfort starts on average just slightly below the midpoint of the scale, which to me is reflecting some ambivalence here. I should also say disclosure comfort at 1 is very uncomfortable, and at 5, the top is very comfortable. So we're seeing it starts just below the midpoint, and it doesn't really increase a whole lot over those first 5 years. This is important because this is a time period when people are vulnerable to relapse and can really use some good social support. And evidence suggests that if people have good social support from their friends and family, that their recovery goes better, is more successful. This graph on the right spans the first 40 years into problem resolution. It suggests that people continue to increase in disclosure comfort, but that this rate of increase slows and begins to level out around 20 years into recovery. What I'm struck by here is that many people don't become terribly comfortable with disclosure, even all the way out at 40 years into recovery. Even at the end of the graph, we're still seeing dots toward the bottom, suggesting that at 30 and 40 years, people are still very uncomfortable with disclosing. I'm currently working on developing a disclosure patient decision aid to help guide people through these decisions in ways that are informed by the evidence, informed by what we know about disclosures. We're currently in phase 1 of the study, wherein we are exploring disclosure processes. So we're meeting with 150 people who are in recovery who plan to tell someone about their recovery in the next 3 months. After those 3 months pass by, we meet up with them again and we ask them how it went. So we've already met with 138 people for their time 1 interviews, and 81 of those have come back for their time 2 interviews to tell us how it went. And we've seen a lot of different types of disclosures among these 81, some that have gone really well and some that have gone not so well. And we're really learning a lot. Our next step is to develop the recovery coral, which is a conceal or reveal decision aid. To do this, we're adapting the coral, the original conceal or reveal decision aid, which was developed to guide the disclosure of mental illness. And I'm looking forward to working on this at the Summer Institute on Randomized Behavioral Clinical Trials, which is sponsored by the NIH this summer. As we saw today,
Did you say what age range that was done with?
Which one? This one? Oh, this is adults. Yeah, this is 18 and over, which I'm happy to talk more about. As we saw today, stigma is also a barrier to HIV disclosure to sex and needle sharing partners. Partner notification is a strategy recommended by the WHO to increase HIV testing, but it's understudied within criminal justice settings. Yet places like Jakarta, Indonesia, many people are first diagnosed within prisons but face significant challenges and barriers to notifying their partners who are out in the community. So I've been working on this issue with Gabe Colbert and a few other colleagues. In one of our studies, a man who is incarcerated told us that he hasn't yet told his girlfriend about his HIV status because he doesn't know how to do it, and also because he anticipates stigma. He's afraid that she'll leave him or that she's going to tell other people, but he also thinks that it's important for her to know in case she does have HIV. We're now working on developing IMPART, which is a provider-assisted HIV partner notification services intervention specifically for incarcerated persons living with HIV. We're currently working on finalizing this IMPART intervention protocol. So just last month, Gabe and I and our colleagues were in Indonesia, where we were holding community advisory board meetings and focus groups, trying to get people's perspectives on how to do partner notification within these settings in both effective but also safe ways. Okay, let's zoom out from the individual and think for a moment about ending stigma overall. Now, there's always some pessimist in the audience who questions whether it's even possible to eliminate stigma. So to that pessimist, whoever you are, I'll say that yes, it is possible. First, I'm going to argue that it's possible because I'm an optimist. But second, I'm going to argue that it's possible because I'm a social psychologist. And I understand that stigma is a social construct. Because it's a social construct, stigma changes. It's malleable. And we have examples of stigma changing over time. 100 years ago, in March of 1919, I wouldn't have been able to vote in this country as a woman. Today, in March of 2019, not only can I vote, which I do, I'm here at the NIH giving this early-stage investigator lecture. And later this afternoon, Dr. Phillips, another woman scientist, will give another early-stage investigator lecture, which is pretty neat. My colleague, Anne Stengel, likes to emphasize that we have many tools in the Stigma Intervention Toolkit. She means by this that we have a sense of strategies that work to decrease stigma. We have tools to address stigma among both individuals living with stigmatized characteristics, which has really been the focus of my talk today, but also among people who perpetrate stigma, as well as within our organizations and institutions. We also have a sense of how to implement these strategies, or how to use these tools in ways that can make them more effective. We know that intersectional, longitudinal, and multi-level approaches, for example, appear to be more effective at addressing stigma. Deconstructing stigma isn't an easy or a quick job, but we have many tools at our disposal to do it. As an optimist, a stigma scientist, I look forward to using these tools through the next stages of my career to chip away at stigma, prevent disease, and promote health. Thank you very much for your attention.
Dr. Ballard.
Hi, great talk. I was struck that one of the first studies you looked at, you were looking at the experience of stigma in 5th grade and then predicted 7th grade outcomes. Now, at least in this area of the country, children are in elementary school or kindergarten through 5,
Right.
and then they go into a middle school 6 through 8. I know from observing my own children that they experienced much more harassment in 6th grade, whereas in 5th grade they were sort of top dogs in their schools in terms of the school of the classroom. They had all their affiliated friends, and that all changed because we merged many different elementary schools into large middle schools. So it would strike me that 6th grade might be a more predictive, if given that school structure, might be more predictive of outcomes than 5th grade, but maybe you could comment on whether that's been looked at.
Sure. The question is whether, to make sure that I have it right, whether peer victimization or stigma or bullying a little bit later, potentially like around 6th grade, is predictive of substance use in later years. That is a terrific question. My hypothesis is that it would be, and it would be, in the same sort of mechanisms, that we've shared today. I know that there hasn't been a tremendous amount of research, longitudinal work looking at associations between peer victimization or these sort of negative experiences with substance use. So I'm not sure if folks have looked at later ages, but given that we see this association, among adults, we see it among young people, my hypothesis would be that we would see it there as well. Yeah, but I think it's really interesting to think about these different time periods because we have theories suggesting that there are, like I said, these moments in time when people might be more or less vulnerable to these experiences. So trying to pinpoint not only how much are they experiencing, which is problematic, but also how vulnerable are they to it is, I think, important. Yeah. Thank you for your question.
I wanted to talk about that early slide you presented as well from a developmental perspective.
Okay.
Thinking you had, at the end, you talked about interventions. And I was just wondering, from your experience in doing this work, it seems like thinking about development early on, addressing stigma early on is an important thing to do. And at what point would you really want to see universal preventive interventions coming into place for to really get kids and into a developmental trajectory where stigma is something that is not promoted within those kinds of settings and systems and groups and interconnections,
Yeah.
but also in a way that you could build that resilience early on in development so that if someone does encounter stigma later in development, they have more resources to cope with it.
Okay. So thank you for the question. The question is, at what age should we start introducing these interventions to both reduce or stop stigma, but also to build resiliency to stigma? And I'm so glad that you asked that question, because we recently did a systematic review of the literature on stigma-based bullying. And we found that we really don't have a lot of interventions that specifically address stigma-based bullying. We have some really great big interventions to address bullying, but not necessarily to get at stigma. And what's problematic about that is that stigma seems to be driven by some pretty specific things that's different than just bullying in general. So prejudice, stereotypes, etc. So from what I know of the literature is that the learning stigma begins early. So kids are learning stereotypes, they're absorbing prejudice very young. And so the younger in those elementary years that we could be targeting youth for these stigma-based bullying interventions, both the ones that overall are designed to reduce it from happening, to try to break up these stereotypes, to prevent the absorption or wring out that prejudice, as well as to sort of inoculate kids to experiences of stigma that they may have by maybe increasing coping or enhancing social support, the better. So, and what's really unfortunate about this is that from what we saw in the literature, that if we take LGBTQ stigma for an example, that was the area that we saw the most number of stigma-based bullying interventions, but they were all for high school. And this, the studies that we're sharing are showing that, well, if these young people are experiencing bullying in elementary school, those effects are already setting in. So we need to be, moving some of these stigma-based bullying interventions that we do have to younger ages, starting at the times when bullying is starting to be harmful. So I would say the earlier the better, as soon as we get the young people into places where we can deliver the interventions. Does that answer your question? Thanks.
We can think of prevention programs in terms of universal prevention, where we maybe work with all of the kids in the elementary schools, for example, or targeted interventions where we're focused on a particular subset, maybe within the school system or certainly a prison population. Is there data from studies that have been done trying to intervene with stigma showing efficacy for either or both of those approaches in any content area?
So are there data showing the efficacy of reducing stigma either broadly or with targeted populations? Yes. So this slide includes some resources at the bottom. So for example, Deepa Rao and colleagues recently reviewed across some of these multi-level stigma interventions for health-related stigma, and they reviewed efficacious intervention strategies, as well as Ann Stengel did a review of the literature a few years ago in 2013, focused in on HIV stigma specifically. So both of these reviews, as well as others, for example, one was recently done that focused in on mental health stigma, but all of these reviews suggest that it is possible to reduce stigma using combinations of these tools. And then the nice contribution of some of this more recent work is suggesting that if we pair these tools together, we can be more effective. So an example of that might be an intervention that was delivered in the UK called Time to Change. So what they did out there was they both tried to do this broad reduction where they were targeting the population at large, sort of the general community, and they were targeting a reduction in mental health stigma. But then they also went in and were targeted about it. So they targeted people I know that they targeted mental health, they targeted healthcare providers, maybe police, and a few other groups that they thought, hey, it's particularly important that we reduce stigma among these groups. I'm not totally sure if they also tried to build resilience among people living with mental illness, but I wouldn't be surprised if they did. So this was a huge campaign. It was countrywide, and what they've seen is reductions in stigma as measured by things like public attitudes towards people with mental illness over time. So I think that that's a really nice approach. So we both have seen examples of interventions that are just targeting communities, just targeting these specific groups, and we're starting to see more interventions that are trying to combine that into one package, and that appears to be particularly powerful.
Follow-up question, if I may. So you're talking about effects on stigma.
Yeah.
Have any of these studies followed
carried it
further
forward.
to look at whether those interventions are subsequently having an effect on substance use or HIV transmission, or pick one of the categories on the health outcomes?
Right. Because I'm a stigma researcher, I'm always paying attention to these stigma mechanisms. I believe that they have, but I'm not sure that I can cite any off of the top of my head. But maybe I'll take a look at that RAL paper and report back to you at dinner.
The reason that I asked the question is that a group like the Preventive Services Task Force, before they're going to endorse a particular kind of intervention,
Right.
It can't just be effective in reducing stigma.
Yep,
It's going to have to. There's going to have to be data showing that there's some effect on a health outcome.
absolutely.
They can combine some of that with observational studies showing that improvements in stigma are associated with improvements in health outcomes. But they're also going to be looking for, quite often, trial results showing health outcome effects.
Right. If we roll back to the choral intervention, for example, that participants who completed that intervention have better mental health outcomes after going through that intervention. So that's one small example, but I'll have to look back to the literature to check on.
Okay. I'm pleased to see that you're starting to move towards intervention research. You've been working in this area for 10 years, 12 years? And much of the presentation was from observational studies.
Right.
That's quite common in prevention generally. Most of the work is observational in nature or secondary data analysis, and only a small fraction is intervention research. Our office is very interested in promoting more intervention research, so good for you. You're planning to, it's not going to be at Early this summer. It's the Summer Institute.
The RCT summer camp?
Yeah. It's been at the Early Conference Center for all these years, but I think it's going to be here in town this year. Glad to see you moving in that direction. I hope more people do, and I hope we'll see intervention studies that have some follow-up and can look at health outcomes too.
Yes, absolutely.
Do you know of studies that are starting to do that, or?
Yeah, so the study that I'm working on with Lisa Eaton, for example, wherein we are doing an intervention to address stigma, the outcome that we're ultimately looking at is HIV testing, for example. So we're working on that now.
Other questions in the audience? All right, well, I want to thank you very much for your presentation this morning. Very interesting, and good to hear about this area, which is an area that I had not been particularly familiar with before, so I appreciate that. I want to thank our audience for coming to this morning's talk. We're going to have about an hour break at this point for lunch, but I would encourage everybody to come back at 1 o'clock for our second speaker, Dr. Siobhan Phillips, who will speak on optimization of physical activity promotion interventions for cancer survivors. And she's here. So if you want to have a chance to chat with her over lunch, she's going to be here. Thanks very much.
Thank you.